Good evening, everyone. My name is Jason Fisher from the RFS Communications Committee. I want to thank everyone for coming online tonight. It's going to be another great webinar. We have the third in the series on leadership today, brought to you by the Women in IR Committee. Just want to do a quick reminder for the RFS disclaimers here that our webinars are always recorded. Tonight won't be any different. Following the webinar, we'll get the recording uploaded to YouTube in the coming days for later viewing. Other than that, you'll notice on your control panel a tab labeled questions. If you click the drop-down arrow next to that, it'll open up a new chat box separate from the main chat, which will allow anyone to type in questions and our panelists to keep track of them as we go. So please enter your questions there anytime throughout the presentation. We've already had a quick conversation with Dr. Vatican, who's going to be willing to handle all questions and field them with his panelists towards the end. That'll let us get through the presentation fairly quickly and keep the interactive portion going for as long as possible tonight. So without any further ado, I'll pass it over to Alex to give you your full introduction. Thank you.
Hi, good evening, everyone, and welcome. This is our third session of the RFS webinar series on leadership. I'm Alexandra Kutsenko, resident at the SUNY Upstate University Hospital in Syracuse, New York, and I'm a SIR-RFS advocacy chair. I want to start with a quick overview of our program. Leadership webinar series were developed by Monica Yuseda and the members of the RFS Women in IR Committee. The goal of the webinars was to educate, support, and encourage interventional radiology trainees, students, and early career physicians to build successful careers, to also acquire some leadership skills, and potentially obtain some leadership positions within the healthcare system. It could be your hospitals, could be your community, medical societies, and possibly even government. And why is this important? Because IR inclusive medicine requires IR leaders in charge. So with that in mind, we developed 10 monthly webinars and invited some of the most prominent IR faculty to present on a variety of topics such as communications, negotiation skills, health policy, team building, diversity, and several others. And today we are going to talk about a very important topic for especially in the early stages of career, and this is mentorship and sponsorship. And I'm absolutely delighted to introduce one of our biggest supporters for all the residents and students, founder of SIR Residents and Fellow Section, and relentless patient advocate, Dr. George Vatican. Dr. Vatican grew up in Florida and graduated from medical school in the University of Miami. He completed his internal medicine internship and radiology residency at the University of Chicago. Then he moved to the West Coast, where he completed his interventional radiology fellowship at UCLA. And then he decided to stay in Los Angeles and continue his successful IR career. So currently, Dr. Vatican is a program director at the IRDR residency at the Kaiser Permanente Hospital in Los Angeles, and he runs his very successful vascular interventional radiology clinic and dedicates exceptional amount of time and work as an SIR resident and fellow section advisor. So Dr. Vatican, thank you so much for joining us today. And as usual, Dr. Vatican brings his mentees and colleagues with him. And today, to our webinar, also on practice shows the power of networking. So network. Let's get started.
All right, thanks for the kind words and the introduction, Alex and Jason. So I'm gonna talk about mentorship in the next hour and have a couple of my mentees and also talk about kind of their thoughts of being a mentee and also what their role in mentorship is, especially when it comes to clinical VIR, and that's what I'm gonna focus on today. So I went to medical school to become a surgeon, really, and you know, when I was on my third year medical school rotation, I was on a hepatobiliary service, so pretty much surgical oncology. And I did enjoy it. I liked the surgeries, the laparoscopic or the open surgeries and whatnot, and the kind of the pathology we dealt with. But what I didn't like was the prolonged postoperative courses that these patients suffered. And so they had prolonged ileases, developed blood clots in the legs, nausea, couldn't eat, were frankly miserable. And so even though the surgery had some life-saving maneuvers, it did result in a lot of discomfort and some element of harm to the patients. So during that same rotation, I saw an elderly gentleman in his late 80s with a Klatskin tumor, who I was like, oh, how is he going to survive surgery? Who underwent a biliary stent by the IR department at Miami, including Swisschuk, who was, I think, a fellow at the time. And the patient went home the next day, and it was like nothing happened to him. Literally, he was older than the rest of my patient cohort, and yet he basically had a Band-Aid on his side, zero pain, was able to eat, and went home literally shortly after the intervention, which was done awake. And that's when I realized that day that minimally invasive medicine is the wave of the future, and interventional physicians were on the forefront of it. And subsequent to that, I applied for radiology because there weren't very many clinical pathways or direct pathways or routes directly into IR at the time. There was only a handful, including University of Pennsylvania, et cetera. So I went into radiology to kind of become an interventionalist. And during that time, I did my internship in a kind of a categorical joint program, UFC, and really profound kind of experience as an intern dealing with life and death situations and kind of, bonding with my patients. And I certainly didn't want to give that component of healthcare up. But during my residency training, I realized that, many of these invasive procedures that, radiologists performed were done with limited consultation with the patient and their family, and even less when it came to longitudinal follow-up. And also, I was surprised by how little we use pharmacologic adjuncts, i.e. the medical therapies that will really potentially be life-saving in patients with significant comorbid conditions, which I routinely used in kind of my internship training. So I decided to go to one of the few kind of, at that time, very aggressive clinical interventionalists who took care of comprehensively his patients and followed his patients for life, Tom McNamara. He did his own wound care service. He saw about 30 patients a week in the office. He marketed very aggressively, and he was such a compassionate physician, obviously a very skilled physician, but more importantly, he was just a solid clinician. And that at that time was a bit more of a rarity. So after I finished that training, I looked at some fellowships or looked at some academic centers to be kind of a junior faculty, continue my training, or a few handful of private practices. One of the things I did do was I made sure that I asked for clinic because I knew how important that was for me. But unfortunately, most radiology programs or radiology, even academic centers, were not willing to acknowledge the importance of that or give me the time to do that. Kaiser didn't have a clinic or formal consultations or admissions, but every other week they would give me a half day of time to kind of figure out what to do. But unfortunately, even during my stint there, right after fellowship, it was mostly a technician role. And I was told kind of what to do, kind of because it came as an order entry for procedure, kind of like an x-ray. And that was kind of again, a little bit daunting and confusing at the time. So, I didn't really like the way that was going and how my practice is continuing. So I was at a fork in the road. Should I continue is this the right thing for me? Because I really wanted to have a patient panel, follow patients in a long-term fashion, manage the disease more comprehensively, or should I go into something else, perhaps cardiology or something that I, always had on my kind of back burner? So this is kind of that proverbial fork in the road. Which way do I go? During that kind of time in the mid 2000s, kind of there was this Journal American College of Radiology, or JACR article, which said, hey, interventional radiology, transformation to a clinical discipline by the famous Barry T. Katzen, who was the founder and medical director of the Miami Cardiac and Vascular Institute, was again one of the original clinicians who realized the importance of clinic well before most others have, an early adopter of it, and it's obviously been highly successful. So because of his kind of approach and kind of was very similar to what I wanted to achieve, I reached out to him via email. And this is him, Dr. Katzen, again, a legend. He runs the ICET meeting in Miami or in Hollywood, in Florida. He's the founder and medical director of the BCVI, or Miami Cardiac and Vascular Institute. So this is my email to him, quite a while ago, a decade or so before. And I go, hey, I'm a junior attending in Southern California. I did my med school at University of Miami, where he actually trained. And I heard a lot of great things about Miami Vascular when I was there. And in fact, some of my co-students had done a rotation there. And for these reasons and others, including some of the work that Michael Dake did in thoracic aortic interventions, I decided to do interventional medicine. I was just a year out of fellowship, and I realized even then, when I started to interact with medical students, they were pretty excited about the field. But the challenge was very few students who really passionate about patient care wanted to spend 4 years in a non-clinical entity. And I wondered why the pathway of dedicated interventional training wasn't more widespread like the direct pathways. So I told him, how I rounded on patients the morning before cases began, tried to see them in pre-op consultation in the limited clinic space that I had, and was struggling to learn clinical medicine at the time on the fly in these, complex patients with either vascular conditions or oncologic conditions or what have you. And, after that, I told him also that, hey, I've been, very excited by the med student interest, and I really want to get the kind of these youth involved in what we're doing. And, I wanted to also get more involved in SIR and have reached out to them, but really haven't heard back to them. So his response to me was like, hey, your frustrations are widespread and regretfully have been occurring for a long period of time. In response to your note, I've copied your note to SIR administrative leadership to circulate, reference that article that he wrote that I had showcased. And he said, hey, stick to your guns. And if it doesn't work out, you as a clinician may need to find a home in another discipline, but let's see if we can get some support for you. So that was a very kind of important, paradigm in my career, where the kind of one of the thought leaders in the society in an endovascular, much less the society, more importantly, in endovascular medicine globally, who he had no idea who I was, reached out to, responded to an email in a very thoughtful fashion, and gave me salient things to work on and got me exposed to the Society of Interventional Radiology. So again, that was kind of a landmark event in my career. And again, mentorship, even if it's remote and someone you don't know, SIR is very profound at that, and our interventional leaders are very, very good at it. So that was one of the kind of the early events that was kind of, important in my career development. Subsequent to that, I went to the APDR. I was invited and went to the APDR meeting just because of my interest in education. And during that discussion, Dr. Kaufman presented this whole primary certificate, which is now the dual certificate or integrated VIR residency. And in that room, because it was changed and people don't like change, a lot of people were not comfortable with this plan. There was a lot of dissent, and I was frustrated that there was a lack of clinical buy-in, that this is the right thing to do. But at the end of that kind of APDR night meeting, the first day, Dr. Kaufman and Peter Lauer, who is the former executive director of SIR, both pulled me aside, and a couple other young kind of faculty at the time, and we had dinner with them. And this is Dr. John Kaufman, who's kind of the head of the Department of Interventional Radiology at the Daughter Institute, and this is former head of the SIR executive director, unfortunately passed away in 2010. But again, these were very impactful mentors in the society, kind of saying, hey, we want you as a newer attending and someone who's passionate about clinical IR to kind of get into the specialty and drive that change and help shape the future. Again, very powerful message sent by leaders in the field of interventional radiology to me as a kind of a young faculty or new graduate. Subsequent to that, I met Sanjay Misra, who has done a ton of research and is heavily funded by the NIH and done some amazing vascular biology research, but who's also very passionate about kind of advocacy in vascular disease and PAD, and got me involved in even giving lectures at the society level. So as a new attending, it's pretty daunting. You have the imposter syndrome. Do I really know the topic? Talking in front of the legends of your specialty, and also the SIR community at large is daunting. And I know now, looking back, and even then I kind of knew in my mind's eye that it was not my best performance. And I knew I probably shouldn't get invited back. But, Misra, he was a good guy. He didn't give up on me. He thought that, I had something to give to the society, so he continued to mentor me. He got me more and more involved in SIR and invited me to more talks and to do more stuff. And now Sanjay Misra is the president of the CVRI, cardiovascular imaging component of the American Heart Association. And it's really important that we help him as he mentored me, I advocate you guys also as mentees to go back and help him with the American Heart Association. So it's something that I want to do for Dr. Misra because of all the help he's given through to me through the society. You know, I had a passion for aortic disease, and I had a, you know, even though I didn't know these two physicians, I knew of them from afar, but I never met them personally. But I got to meet them at SIR and at other meetings, and they were so easy to talk to, and even simple questions that I had about thoracic aortic interventions or aortic disease and technical parameters or clinical parameters. These two gentlemen, Michael Dake, who was a former head of the UVA and chief of Stanford back in the day of interventional radiology, and now in the Arizona, the state of Arizona. And Alan Matsumoto, Dr. Matsumoto just gave the recent daughter lecture. These are both two daughter lectures, two presidents of the society, who again, you know, even though I was very junior faculty and just showcasing interest, they again were very open to kind of mentoring me from locally and from afar. So very important in my development as a clinician as well. And Dr. Matsumoto got me more involved in the American Heart Association in the early career development with Alan Hirsch and others. So again, these are the kind of the mentors that I've had to guide my career, my development, and my passions of vascular disease. And this is us, though it's a blurry image. This was at the ISET meeting. And again, it goes beyond the professionalism. It's also kind of a social networking that we had. And again, sharing ideas of how to treat complex aortic disease. And so again, I've learned a lot from them. Dr. Beninati, who's the program director of the Miami Cardiac and Vascular Institute, probably one of the premier fellowships in vascular interventional radiology, something that's very sought after. Though I couldn't get into it, two of my colleagues are Miami Cardiac and Vascular Institute graduates, Dr. Alok Bhatt and Dr. Ken Lam, who I also mentored both of them. And I'm lucky also to have Dr. Beninati as a mentor and a friend who's guided me. And I have asked him and spent 45 minutes on the phone talking to him about, hey, how do you select a student and identify them as going to be a future clinically aggressive interventionalist who's going to want to comprehensively manage patients, because he's successfully done it for several decades. Now, one thing I want to talk about is the importance of mentorship. It can not only come from your group of physicians, but from others. So if you look at the Society of Cardiac Angiography and Interventions, which is basically the interventional cardiology equivalent of SIR, it was founded by these two gentlemen, okay? Melvin Judkins and Mason Soanes. So if you hear the back history, that exciting time of interventional medicine where Daughter was there, Amplatz was there, Soanes, Grunzig, et cetera, one of the exciting things is their cross-collaboration amongst specialists, different specialties. So Mason Soanes was a pediatric cardiologist who inadvertently fell into the coronary artery and kind of developed coronary angiography. And Melvin Judkins was one of the first fellows of Charles Theodore Daughter, and he was at the Oregon Health Science University at the time. And Starr, who's a cardiac surgeon, asked him, hey, I want you to learn coronary angiography for my patients who have valvular disease, et cetera, so I can assess their coronaries before I go in to do the cardiac surgery. So Judkins went over to Cleveland to work and learn under Mason Soanes how to do coronary angiography. And then Judkins figured out, instead of going from a brachial approach, I could do it from a transfemoral approach. And now it's flipped back to radial. So it's it always goes back to the past. So these two collaborated and were friends and developed that society. So I've had mentors outside of my own specialty, like Mani Mehta and Dr. K here, who are kind of very passionate about aortic disease. And I met them at meetings and talked to them and had dinners with them about aortic disease. We've showcased a passion for a disease. And again, it's something to look for. Is you don't necessarily only have to go through your specialty. And in fact, I encourage you to look outside your specialty, learn about diseases, and look for acknowledgement also outside of our own little societies. Now, another thing is, where is mentorship? When you're an early care attending, you have to recognize there are complications that are going to occur. And, I came into a new job, didn't know anyone there. My first week, I had a complication of a lung biopsy with air embolus and air fluid level in the left ventricle. Now, luckily, I remembered to put them on, side, kind of head up or head down and, things of that nature, and put him on high oxygen, not 100% non-rebreather. And he did okay, but it really did shake me to the core. And I met Tej Nanda through friends of mine, and he was kind enough to spend, countless hours kind of just guiding me through that whole process and dealing with the repercussions of an early complication. So I think that's also important when you're looking at mentors, someone you can confide in, because your family won't really understand the scope and breadth of what you're doing and the impact it has on an individual's psyche and confidence. So again, these are, again, important mentors that I've had in my life, who Tej is now one of my really close friends who I pretty much meet every year at this SIR meeting. So some of the other things that I want to talk about in mentorship and impact factor as you look forward. So I tell my trainees 15 minutes in an IR clinic is preferred to an hour in the IR holding area. And I feel, this is my personal bias, 15 minutes with a medical student is worth more than a month with a resident and worth more than a year with a fellow, because the impact factor early on is so great. Now, we developed this mission statement about clinical IR, and it included really becoming disease experts and focusing on patient-centered care, and really focused on trainees. And this is something the society focused on fellows and faculty, but they didn't really focus on residents, much less students. And that was something that I thought was really important. And initially, they really didn't comprehend the importance of that, but now, obviously, because of the success of our RFS, they clearly understand it. And again, the goal was to really focus on the new pathways. Now we would say the dual certificate or integrated pathway and the ESIR, and delivering longitudinal patient care and the focus on clinics. So these are things that I think are really important as resident-run clinics, longitudinal comprehensive care, and again, these integrated pathways. And our primary focus in the RFS really is to focus on the patient as opposed to procedures. And I think that's really important that we don't forget that component, because though the procedures are cool and elegant, it's ultimately about the individual and their social interactions and the disease and burdens that they're dealing with. One of the other things that I found very important, and it's really important to identify mentors in the various disease service lines, is that instead of thinking about procedures, we should be thinking about service lines or organ-based systems and diseases. So in the brain, stroke, really, carotid disease, vascular peripheral arterial disease and critical limb ischemia and claudication, venothromboembolic disease, whether it be deep venous thrombus or pulmonary embolus, cancer conditions, prostatic hypertrophy and urinary tract syndrome, infertility, palliative and pain procedures, etc. So again, it's really important that we build all these different service lines. So realizing that, I knew that though we're recruiting the right people, we have to change training to accomplish that goal. So it starts as early as medical school, and that includes the third year of medical school. Internal medicine and general surgery should be your focus to get your foundation for interventional medicine. And your fourth year has to be broader than it historically has, meaning really you need multiple sub-Is. You can't do one IR rotation if you're planning on applying for integrated. I think that's foolhardy. You need 3 busy sub-Is, and I say the 3 C's of a busy sub-I should include clinic, consults, and catheter time in that order. I see too many trainees spending their time in the operative suites or in the clinic instead of the clinic or doing formal consultations, and I think that's a travesty, and we have to change that. Vascular surgery with a combined endovascular is a great rotation. ICU is a must. Either cardiology consults, stroke neurology are important, and I do think a surgical sub-I of some sort to prep you for your surgical preliminary are very important. So again, surgical internship, your PGY 1 year, and this is what our integrated has, and they do a month of vascular surgery, a month of ICU. Again, ICU and endovascular are really important during surgery year, but if you can get them IR month, great, it's just gravy, it's not critical, but I think these two are pretty important, including surgical oncology. So surgery internship is really kind of the way that I think we should move going forward. So as far as ICU training, it's really critical. In our training program, we get about 6 months of ICU training, including the MS4 year. And it's because we're dealing with super sick patients with poor ejection fractions, aortic valvular disease, mitral regurg, mitral stenosis, end-stage renal disease, COPD, end-stage liver disease, refractory ascites. And so I think bleeding patients with master infusion protocol, septic patients on multiple pressors. And so really 1 month of ICU, the PGY 5 year, is kind of again, a travesty and inadequate. And so really it starts in your 4th year of medical school with a unit, and internship must have at least 1 unit, if not more. And then with our organization, we do nights and weekend shifts of PGY 2 year, and then a month of CCU PGY 3, and then a couple months for PGY 5 and additional months PGY 6. So you're getting at least 6 months of intensive care training during your career, and that will help you to manage these very sick patients, pressors, vents, etc. And I think that's exceedingly important. Now, another thing that we need to train our residents and students better in is how to kind of evaluate and manage patients in the office-based setting, how to guide and counsel patients in the office. Again, as I mentor multiple students around the country, we have about 3 to 5 students rotate every month. Many end up in an integrated program somewhere. But one of the key things I tell them is the importance of clinic and the importance of seeing a patient there, the importance of guiding them. My primary job is a guidance counselor to help them through their illness and through life and the situations that they have to deal with. And it doesn't end with the procedure, and it doesn't end until, you know, I don't give up on them, and we can't give up on them. We keep on fighting with them, and whether that's at hospice or palliative care, wherever it may be, and end-of-life discussions are a big, important component of a VIR practice. So our residents do a half a day of clinic throughout their PGY 2 through 6 years. So for 5 years, a continuity clinic. So as many of them are holistically managing patients, and hopefully Karthik and Zara can talk about a little bit about this during their residency training. And that includes, you know, diet and exercise protocols, making sure they're optimizing our statins and metformins, and screening, mammographies, colorectal cancer screening, etc. And I think that's an important component of what we do for patients, period. And it should go beyond our procedure. Like I said, it goes beyond the disease. It goes to looking at globally how to impact the patient's life. And then PGY 6, we continue more of kind of the interventional with stroke and peripheral call. So that's kind of what we are doing at our facility, and I encourage more and more people to integrate more clinic and more ICU during the PGY 2 through 4 years to kind of really get ready to take care of people properly. So through the SIR-RFS, I've been very lucky to mentor and work with a tremendous number of amazing, very passionate and compassionate, most importantly, medical students, both locally, regionally, nationally, and now even internationally with some of the United Kingdom students. And they share our common goals of taking care of people comprehensively and providing longitudinal follow-up. And I think that's very important. So I do think we have to have a similar vision of mentor to mentee. So I don't, you know, if someone's a pure proceduralist and doesn't really want anything to do with patients, I don't think it would be a good fit for me. I think they have to showcase their compassion for individuals and their passion for interventional medicine. We try to dedicate some time to the mentoring process. It takes hours to do this. So though I say 50 minutes, it's really countless hours that we spend with these trainees. And we should be available and responsive. Otherwise, I feel the mentee will feel deserted. And ultimately, I think it's exceedingly important that that amount of time that I spend with them, that the mentee pays it forward as well. And I do hold them accountable for that. This is me and Mark Raymond and one of my mentees, Ken Lamb, who's now one of my colleagues. And so we're part of the original kind of VISLA group. This is me with Dr. McNamara, just his picture, because he got the Leaders in Innovation Award in 2018. And you know, I hadn't seen him in quite a bit of years. And so I figured at least I could get this picture with him. But even better, I saw him at the Hyatt Hotel in LA, and I was able to actually get a face-to-face picture. This was very meaningful to me, to at least let him know how much he meant to me and my career as a clinician, physician. And these are some of my mentees. Amit Baklu, Alok Bhatt. Amit Baklu went to University of Michigan, now is a CLI fighter. Alok Bhatt, who's also a CLI fighter, and a colleague of mine, but I knew him as a third-year medical student. And now he's one of my colleagues, and he trained at the Miami Cardiovascular Institute. And now Andy Niekamp, who was one of the heads of the RFS, and is now just starting his fellowship year at the Miami Cardiovascular Institute. And obviously my mentor, one of my guy who brought me to California, Tom McNamara. So very exciting to have kind of my mentees and my mentor kind of all meet. That was a special moment for me. This is a patient that Karthik and I did one of our first kind of pedal loops, and she was a 40-some-year-old who was not offered anything besides a BKA, and so kind of she had Berger's disease, heavy smoker, and we were able to salvage her to transmetatarsal amputation, and she was so grateful that she jumped onto the National Committee for Berger's to convince people to stop smoking and become a big spokesman for that. And that excites me in the fact that our intervention and our care for this patient really promoted her to push that care to a lot of other patients. So she's kind of a mentor for other patients to stop smoking in the Burgess Foundation. So I think that's exciting too. So it goes beyond just students and residents, but really our patients are also mentees and mentors for us. So again, this is in Austin, getting to hang out with my mentees, Farad, Karthik, and Andy at Austin at having some barbecue together is also kind of a fun event. So I think this was a cool time that we had again in Austin with a bunch of students and residents, and I was here really getting a good chance to talk to a lot of very excited, motivated trainees, and so quite a fun time to kind of hang out with them in a more social outing. So kind of want to thank you for giving me this opportunity to kind of talk about my experience with mentor-menteeing and networking, and that goes beyond students and residents, but also really to your patients. And patients have tremendous impact and downstream impact in what you do. So that impact factor is great with students, residents, fellows, young faculty, and even your patients. So that's pretty much the gist of what I wanted to talk about, kind of my experience of mentoring, my experience with the residents and students and whatnot. And so I wanted to kind of continue this conversation with some of my mentees. Some are now my colleagues, some are my residents, some are my current sub-interns. So Varun Singh is, I started working with him. He reached out to me through SIR Connect mentorship program, which is something that I encourage any student to get onto and reach out to faculty. And I've been working with him subsequent to that. And now he's actually on rotation with me this month. He might be a little tired, but hopefully he'll be on the conference call. And then I have Karthik and Zar, which are two of my PGY5s. Karthik is our Vista integrated resident, and Zar is our ESIR resident. And so they'll be talking as well. And then finally, but last but not least, my colleague, friend, mentee, and now he's a great mentor for a tremendous number of students that go through our program and residents and whatnot. And that's Dr. Ken Lamb, who trained at the Miami Cardiovascular Institute after residency with me at VISLA, and he came back, and he's a CLI fighter as well, and a huge advocate of trainees. Thank you.
Thank you so much, Dr. Vatican Cherry. This is a very inspiring story, and so many giants of medicine influenced your path, and now you influencing our path. So from the panel, would anyone have any questions? Who wants to tell any other stories?
Good evening, everybody. This is Matthew Sarteon. I'm a ESIR PGY5 at Kaiser Permanente. You know, I just want to share my own experience from a mentee perspective. As a med student, I was interested in family medicine. All of med school really was fascinated by the doctor-patient relationship, longitudinal aspects of care, and fortuitously, I ran into Dr. Vatican Cherry. And you know, it reminds me of a saying: when you find a human of great wisdom, wear out their doorstep. So that's kind of what I did. I just kept showing up. I liked the way Dr. Vatican Cherry and the rest of his colleagues really did embody this clinical interventional radiology perspective, really following their patients longitudinally, managing their care over the long term, in addition, of course, to the diagnostic imaging expertise and procedural acumen. So I just kept wearing out his doorstep. And I think the real key, something I really valued, was the challenge. Dr. Vatican Cherry would always challenge me. He would find out where I have flaws, where I have weaknesses, and as a mentee, I really had to take that with humility and be responsive to growing on those weaknesses, being honest with myself, those weaknesses that have been pointed out, and taking that as a learning opportunity. And that's really the biggest value I took. Rather than seeing things, my mistakes, my flaws as failures, I was just responsive to them and really took them as opportunities to grow. So through the years as a MS4, PGY1 intern, really built on my history and physical exam, as a radiology resident, not only just focusing on the diagnostic imaging, but as a clinical diagnostic and interventional radiologist. And now as a PGY5, was grateful to have matched into UT San Antonio for independent IR residency. And I'm really grateful for having Dr. Vatican Cherry as well as others as mentors. Thank you.
Thank you, Matthew. That was a very, very interesting and nice perspective. Very important. Kartik, maybe?
Yeah, so my name is Kartik. I'm, like as Dr. V had said, I'm one of the PGY5 integrateds at Kaiser. I when I was a student, I used to remember always hearing people say, you know, it was just by chance that I met my mentor. You know, ever since I met my mentor, my career has been great, and it's been a lot easier. And I always thought, how do you just luckily find someone? And that's kind of what happened with me. Interesting in Dr. V's PowerPoint, in that last picture, in the top left, there's Dr. Caridi, Jim Caridi at Tulane, where I went to med school, was actually the first person that introduced me to IR. And he used to see patients in his office, and he just didn't have the support kind of at that time to build a full clinical practice, but he always believed in it. And so then I luckily came to Kaiser to do an OA rotation only because it matched up with my schedule. And that's when I met Dr. V, and I was just like, holy crap, what is this? And I was just amazed at kind of the clinical model that they had built, and what I saw, the way they were practicing IR. And then during that month, I also kind of built this relationship with Dr. V. I was fortunate for somehow I was the only student on, and there wasn't a resident on, so I spent a lot of time with all the attendings, and I got to know them all very well. And I was just kind of always just amazed at how much of an genuine interest they all took in me kind of improving as a student, going on to do the best I can. Especially Dr. V, he would spend hours explaining things to me. If you know me, but he'll tell you, I'm the first. I'll ask 1,000 questions till I know something, or any thought that's on my mind, I'll put it out there just to get better. And he would be very patient with me the entire time. And kind of through that, we've built this mentor-mentee relationship that has really allowed me to become the doctor I am now, and hopefully kind of continue to grow. And with that, I always kind of ask him, I was like, how did you build all, the networks you have? Because whenever you go to these meetings, if you've ever walked like 10 feet with them, you realize you're going to get stopped 1,000 times. And he'd say, I just talk to people. And I think that's something I want to kind of talk about, the IR community. We're all so welcoming. It's a very small community, but every single person I've ever met is extremely friendly. So, whether you see me or anyone, if you want to meet someone, just approach them. I've never once had a bad experience with an IR, doctor at all.
Thank you, Kartik. Thank you.
Varun or Ken on the phone?
Yeah, sure thing. Hi, thanks for having me, everybody. My name is Varun Singh. I'm a fourth-year medical student from Jefferson. I'm also currently doing my sub-internship at Kaiser, Los Angeles, with Dr. V and Dr. Lam. So I just wanted to give a quick amount of information about my mentor-mentee relationship and how it came about. So essentially, when I was a second-year medical student, I was part of the Jefferson Interventional Radiology Interest Group. And there was a fourth-year student at the time named John Doe who had done a VISLA sub-internship and suggested that I reach out to Dr. Vatican Cherry by way of SIR Connect. So I did so and eventually met up with Dr. V at SIR 2018 in Los Angeles, and then subsequently at academic IR in DC that September, and then in ISET and the following year SIR in Austin. And throughout all this time, Dr. V kind of, even in the preclinical phase, modeled my perception and understanding of disease and instilled from a very early perspective that we're not technocratic in interventional radiology, but seek to understand holistically the disease process and the patient and manage those disease processes clinically. So that really helped my third-year education going into rotations like medicine and surgery, and even rotations like psychiatry, understanding the holistic patient and the holistic person. So one way that I learned to kind of pay it back and pay it forward is I currently serve in a role as a vice chair of the education committee of the Medical Student Council of the SIR. And in that, we have established a flagship education project for the year known as the Introductory IR Curriculum, which instead of discussing things in a technocratic, step-by-step approach. We approach things just as Dr. B was discussing earlier by way of the organ systems. And we've established these organ domains and body systems by which we can educate students from the earliest preclinical phase of education about specific disease processes and clinical management. About the mentor-mentee relationship, I found that interventional radiology during my sub-internship is exceptionally rewarding, but also exceptionally challenging. Like there are definitely a lot of highs and lows during my sub-internship even now, and I have to say that mentorship is truly invaluable, and finding those mentors is a blessing truly. Like Dr. Vatican Cherry, and in fact all the attendings here at VISLA where I'm doing my sub-I are incredibly patient, go over tons of imaging and clinical management, and really ensure that myself and all the other sub-interns are really pushing ourselves and pushing our knowledge and our clinical and technical acumen, but most importantly to really understand the patient and in full consultation with their wishes and their desires and their entire health, not just technocratically doing one procedure versus the other.
Thank you, Varun. Is Dr. Lam there?
Thank you.
Hello, can everybody hear me?
Yes. Hi, Dr. Lam.
Okay, good evening, everyone, and thank you, Dr. Vatican Cherry, for having me, inviting me onto this panel. And thank you to the RFS leadership for adding me on at the last minute as well. Just real quickly, I want to kind of tell a quick story about kind of how I fell into Dr. Vatican Cherry's mentorship. And a lot of times, you know, in life, things kind of happen serendipitously and, you know, kind of unintentional and just by accident. And before I even started medical school, I actually met an interventional radiologist who happened to work at Kaiser Los Angeles before we were VISLA. And, you know, he told me he was an interventional radiologist, and just like, you know, the public, you say that and everyone asks, well, what the heck is that? And so he invited me to shadow him. And so I kind of saw a little bit of the work being done at LAMC, and it just kind of blew my mind. And so I always kind of kept my mind open about, okay, well, maybe this thing called IR, it might be a cool field for me in the future as I enter medical school. And going into medicine, I was always interested in just being a doctor. I wanted to take care of people. And that was just my passion. I didn't quite know what I wanted to do, but I just knew that I just wanted to take care of people. And I thought going into my first and second year that maybe I'd pursue internal medicine, maybe cardiology, maybe even interventional cardiology. But as a fourth year student, I actually did a formal rotation at LAMC. And I think this is when Dr. Vatican Cherry had just been on maybe a couple of years. And again, saw a wide variety of, you know, incredible cases. Now, this was part of Dr. Vatican Cherry's kind of formative years as well as a young attending. You know, didn't have a formal clinic. We saw some patients, you know, in the conference room, walked patients over to urgent care to check vitals. And it was just blew my mind that as a doctor taking care of patients, we don't have, you know, the resources to take care of them, you know, in the way that we should. And I was lucky enough to match at LAMC for residency in diagnostic radiology. And again, you know, my internship was in medicine and I just loved it. So I just tried to learn as much as I could about, you know, the pathophysiology and try to take the best care of the patients that I was on my panel, take care of all the patients that on my entire team, and then just kind of took everything to heart. And I think, you know, if you exude passion for just taking care of people, if you exude passion for just kind of, you know, your future career, that this is a honor, this work that we're doing, you know, people recognize that. And I didn't seek anything out. It's just that this is what just drove me every day, you know, no matter how late the hours were, to just keep grinding and keep going, because the end point is when somebody leaves the hospital in a better condition than they came in, it just made me feel like it was all worth it. And after my internship, Dr. V, you know, caught wind that, hey, you know, this guy is really kind of working hard. And he said, hey, I know you're interested in IR. Do you want to do this IR pathway with me? And I didn't quite understand what exactly he wanted me to do, But I said, sure. And, it's been a wild ride, but, I was able to, do incredible things in terms of taking care of patients, helping him, just kind of seeing the evolution of our clinic, our own practice, seeing the struggles that we have to face, just to kind of do the right thing for the people that we're taking care of. And as a resident, he gave me incredible responsibilities. We're going to go to SIR and, let's see what we can do there. And, we took on this mission to try to improve and grow the pre-existing resident fellow section to kind of what it is now. And just the journey that we've been on, the challenges we've faced over the years to try to inspire the future of IR. I mean, who gets an opportunity like that? And again, things kind of happen by accident, and it's hard to kind of have this type of webinar and have this panel. It's like, well, how do you find a good mentor? And I think part of it is that you got to be true to yourself. You got to, like, if medicine is what you want to do, if medicine is your passion, people will see that. And sometimes you don't need to go out and find a mentor. A mentor will come and find you. And, we see people out there that just, their hearts are in the right place. They're grinding day in and day out. And, no matter how long these days are, there's always a smile on their face and they ask for more. And we see those folks and we say, hey, why don't you come with us and, let me help you on this journey and see if we can guide you along the right way to this crazy field called IR. And, it's an incredible, incredible career. And I can't thank Dr. Vatican Cherry enough, for everything he's kind of given me in my life, to be where I am today, to be able to care for the patients that I care for, to kind of have this career fulfillment, it's just an incredible, incredible thing to have. And like I said, you don't have to, if you exude passion, the mentors will find you. And I know it's a hard thing when you're a student out there and, the field is so competitive this year and in the recent years. And it's easy and very, very easy to kind of get lost in the sea of all these, gung-ho, super, super qualified, candidates. But again, just be true to yourself. Be there, be present, be engaged, be proactive, and the people will find you, and like you said, we're happy to have you come and rotate with us to see how, we practice medicine, how we practice IR, because we think it's the right thing to do for our patients. We think it's the right thing to do for our field. And we hope that, we inspire you to carry on that message moving forward so that, the future of our field will continue to be bright. And again, I can't thank Dr. Vatican Cherry enough for kind of showing me and guiding me along my journey. And hopefully all of you will find that person or that person will find you to help guide you along your journeys as well. So thank you all.
Wow.
Thank you so much.
Thanks for all those kind words. Yeah, but yeah, in reality, you can see that the mentorship, the mentee relationship, you become almost colleagues and friends. And so it's a very kind of unique thing that you can develop. And it can come from anywhere. It doesn't have to be your specialty. It doesn't have to be, it could be your seniors or your juniors. I've been mentored by people who are junior to me in as far as training goes, but that you can look for it anywhere. And it now has no boundaries. Again, international mentoring is capable. We're capable of doing that because of emails and WhatsApp, etc. So I don't think you have to be limited geographically anymore. But ultimately, the mentorship that I've been pushing is for really changing the foundation of medicine and the way we practice as interventional radiologists and vascular interventional radiologists into a more comprehensive clinical fashion, the way that Barry T. Katzen, who was mentors to Dr. Lamb as well, and Tom McNamara envisioned, my former attending. So that's what I hope happens as we move forward. And I encourage all of you to kind of pursue this. And again, the mission statement, the reason for being of the RFS is really that. And I don't want us to lose sight of that ever. It's about the patient and the patient's kind of not only their medical condition, but their health and well-being and happiness and social condition and their family interactions. That's pretty much it from my standpoint. Thank you.
Thank you so much, Dr. Vatican Cherry. Thank you, Dr. Lamb. Thank you, Kartik, Matthew, and Varun. So many great stories today. And I absolutely agree that interventional radiology has this unique nature, very responsive and caring leadership. And we have so much, so important mission to carry on building strong, comprehensive, clinical, minimally invasive medicine. So we have to work together and be grateful for everyone who is mentoring us. And whenever we get a chance, we should pay it forward to other residents and students. And if anyone have any questions at this time, unfortunately, I think our webinar is coming to conclusion. And I definitely want to thank everyone for attending. And Dr. Vatican, thank you so much to you and your team for this amazing webinar. Your contribution is really valuable to all of us in our community. And for those who could not join this webinar from the beginning, we will be posting the recorded version on RFS YouTube channel. And I do highly encourage everyone to join us in August as well for our next leadership webinar with the pioneer and legend of IR, Dr. Barry Cutson, speaking on importance of teamwork, which is quite a continuation of Dr. Vatican talk on mentorship. So thank you so much, everyone.
Thank you, everyone. Have a good evening.
Thanks.
Yeah,
Thanks.
thank
Have
you.
a good evening.
Can't wait to hear my mentor talk and Ken's mentor.
Thank you.
Thank you. Thanks, Alex.
Thank you so much.